it really is a pleasure to be here. When I developed this slide, I have to say that I had no clue that the predominant representation here would be women. But I know that women play a very important role in the management of prostate cancer in men. Women tend to have husbands, lovers, partners, brothers, uncles, fathers, and sons, and very often the women are key in seeing their men through the often difficult and challenging path that prostate cancer patients follow. So can we have the next slide, please? So just a quick plug for the Ralph Lauren Center, which was developed 15 years ago to address the disparities in cancer care and outcomes in Harlem and surrounding communities. We have a beautiful facility where we offer screening, prevention services, including nutritional services, and treatment for most of the common cancers and blood conditions. Okay, let's move on. We're located in East Harlem, near the subways and the Metro-North station. Next slide. So, prostate cancer is the most common cancer in men, and it's the second most common cancer killer in men. What you should notice is that although approximately 165,000 men are diagnosed each year, only 30,000 die. So the take-home point here is most men with prostate cancer do well. Next slide. So this is actually the first time that the American Cancer Society, which yearly publishes its cancer statistics, has shown a separate breakdown for African Americans. It's the same story, only a little bit worse. Prostate cancer is the most common cancer in men. Prostate cancer is the second most common killer, but the percentage of cancers that a burden is higher in African American men. Let's look at the next slide. So this is the most important slide, and these numbers really should raise red flags, and people should be up in arms, batting down the hatches to deal with this. And basically what it tells us is that the likelihood of getting prostate cancer is more than 1.5 times higher, almost 1 3/4 times higher if you're an African American man compared to a non-Hispanic white, and that the likelihood of dying of prostate cancer is more than 2 times the likelihood of a white man dying of prostate cancer. Now those are absolutely startling numbers, and it just cries for research and activity to change that. Not shown here, and because the data is not as solid, but it's very clear that if you are a Caribbean man of African descent, your risk of both getting prostate cancer and dying of prostate cancer is even higher than if you're an African American. So, next slide, please. So why is there such a big difference? And the real reason is the real answer is we don't know all the answers. Genetics clearly play a factor, and we've begun to identify certain genes that are maybe players in that. Environment, question mark. Diet, we know in general that eating a diet that is not good for your heart, high carbohydrates, high animal fats, high red meats, is not good for prostate cancer. Culture obviously is not going to affect incidence. It may affect outcomes, and we know there may be resistance to screening, and we'll talk about that in a minute. And access to care. All of these factors may be contributing to these wide disparities in prostate cancer incidence and outcomes. Next slide. So what is the prostate gland and what does it do? I don't know how well you can see this. The prostate. You can remove that. Remove that. The prostate gland sits deep in the pelvis. This is the bladder, and you can see a tube through which urine normally flows out, and that passes right through the prostate. Also, this duct is the passage through which sperm and ejaculate passes. So it sits at a very critical position, and it's involved both in urinary and reproductive function. You can see if this gland enlarges, either from benign prostate enlargement, which is very common and is also can be a serious illness, or from prostate cancer, the bladder cannot empty because the urine can't get through that little tube. Urine backs up and people can go into kidney failure. But it also, before that, it can cause a lot of symptoms. Now, most of the symptoms that men have are very nonspecific. So it's very common for men as we age to get benign enlargement of the prostate cancer, which can cause the exact same symptoms. So what is the importance of the prostate gland? It contributes to the ejaculate and helps facilitate fertilization. If you want to be cynical, its job also is to create anxiety for men and business for urologists. I hope there's no urologists here. Next slide. So what are some of the common prostate diseases? Prostatitis can be a non-infectious inflammation of the prostate, usually occurs in younger men and gives them symptoms of discomfort in the lower abdomen, urinary frequency, incomplete voiding. A bacterial infection of the prostate is usually more acute. And I did mention benign enlargement, which is something that needs to be treated, very common. We know that African American men also are at high risk of having kidney failure from other diseases. So if you can't empty your bladder from even without prostate, just from benign enlargement of the prostate, that can cause kidney failure. So the take home here is men who are having urinary symptoms should be checked out by a urologist for both benign enlargement of the prostate and prostate cancer. Some of the symptoms, as I said, are very similar: frequency, incomplete voiding, waking up at night to urinate, decreased size of and force of stream, occasionally blood in the sperm. But most patients with early prostate cancer have no symptoms. That's why we have to do more to screen them. Next slide, please. So what are the risk factors? Well, if you want to avoid all risk of getting prostate cancer, then just get born a female. That's easy. But clearly this is a disease of older men. There's a mild family tendency. I mentioned earlier the disparate impact of race, and there may be some genetic factors. Inflammation, overweight, and unhealthy diet may also contribute. Next slide. So prevention. What can you do to prevent it? Well, again, be born female, watch your diet. There were 2 drugs that were tested and shown to have a mild impact on reduction in prevention of cancers, but it seems that most of the cancers prevented were the insignificant ones, and yes, some prostate cancers are insignificant, not dangerous, and don't need to be treated. The reason I put this slide up here is that, and this will be echoed in the next slide about screening, that in both the prevention studies and the screening studies, take a guess, just take a wild guess of what percentage of men in these studies were African American. How many think 20% or more?
Less.
Okay, how many think 10% or more?
Less.
Right, it's somewhere in the 3 to 5% range. So we don't know if it's possible that these 2 drugs, they're 2 drugs, names are not important right now, the overall impact was minimal or very modest, but it's also possible that because there were so few African American men in the trial, that it might have a much bigger impact on African American men. It might be a much more useful drug for African American men. Could also be the opposite. This and the next slide about screening point out the importance of getting more African American men and women for other cancers into clinical trials. And my colleague, Dr. Carol Brown, is going to talk about that in detail, I think, later on. In terms of screening, you may have been following in the news that it's a little controversial. There was some disagreements about whether people should be screened or not. There are several large trials that showed screening does reduce mortality from prostate cancer. That's the take-home message. Again, very small amounts of African American men in these trials. One of the largest trials was done in Sweden. Duh. So again, it emphasizes the need for African American men and women to participate in trials. Why aren't there more African American patients in clinical trials? Well, I think there are many factors. There may be distrust of the medical establishment, particularly because we all know the history of experimentation on African Americans, so it's a very reasonable concern. And we also know more and more that there is unconscious, hopefully unconscious, not conscious bias by white doctors when dealing with African American patients. And those are things that have to be overcome. Take-home message, screening works. We recommend screening for all African American men beginning at age 40. And I'll be happy to answer questions about that later. Now, who shouldn't be screened? Older patients who are likely to die of another disease in the next 5 or 10 years. But otherwise, all men should be screened. Going forward, we're looking toward more precise screening techniques that might be able to identify men and say, you really need to be watched carefully, you don't have to worry, but we're not there yet. So how do we screen? Next, please. Basically screened by the digital rectal examination, which can pick up large tumors, but really can't pick up small tumors. It's still a very important part of the exam because it can also diagnose a very enlarged benign prostate. We know there's tremendous aversion to that, and let me tell you, there's no particular culture, race, ethnicity, or sexual orientation that likes a digital rectal exam. Next slide, please. And the second arm right now of screening is a blood test called a PSA test. PSA is a chemical that's made by the prostate. It's made by normal prostate cells, but much more of it is made by cancer cells. It can be elevated in many different conditions that are not cancer. So if you or your male loved one has a high PSA, it does not necessarily mean they have cancer, but that means that you have to look into it a little more. The PSA can be affected by various activities, medications, and so on, and there are ways of tweaking the PSA, but basically it's a blood test that we use. Next slide. So who needs a biopsy? Well, clearly if the digital rectal examination shows a really hard bump or lump, that should be biopsied. And if the PSA is elevated, biopsy probably should be done also. Again, there are ways to tweak it, but basically those are the criteria. I made the point earlier that sometimes we do find prostate cancers through the screening process that don't need to be treated, and it causes a lot of anxiety, but not every prostate cancer is dangerous. Next slide. So what are the treatment options? Well, for patients who have localized prostate cancer, surgery and radiation are the most common treatments. They are effective, but they do occur at the cost of some quality of life issues. The major concerns are urinary control, where the issues are generally temporary, and probably the thing that most men are concerned about is the impact on sexual function, and that's true for both surgery and radiation. Another option is active surveillance, and these are for men who have prostate cancer that when we look at under the microscope seems to be very unaggressive. It's a small amount, their PSA is low, and we know now that we can watch these people, and we can spare a lot of these men more invasive and life-changing treatments. And many of these men can do well for years and years and years before they need treatment, and many of these men may never need treatment. They'll go on to die of some other disease. But that's only for prostate cancers that under the microscope don't look that aggressive and is in small amounts. For advanced prostate cancer, the mainstay of treatment is anti-hormone therapy. It's getting rid of testosterone. We've known since the 1940s that for men who are suffering with prostate cancer, in those days, they would only be diagnosed when they were very advanced. They were in pain, they were weak, they couldn't urinate. In those days, the way of getting rid of testosterone was surgical removal of the testicles. We don't have to do that anymore. We have medication that lowers testosterone. And does the same. That's still the most effective treatment for advanced prostate cancer. We sometimes use it in conjunction with radiation for earlier prostate cancer. The side effects have to do with weight gain, hot flashes, just like going through menopause. And when I sit there with a man and his woman who accompanies him, and I'm telling them about the side effects, usually the women are sitting there nodding, yep, because they're used to this. Next slide. So, I've given you a lot of scary news over the last 10 minutes or so. Is there any good news? I don't know if are there any grammarians here? You know, should that be, are there any good news? You know, there's the old story about a journalist on some far-flung post, and his editor sends him, hasn't heard from him for like months and months, and sends him messages, are there any news? And the journalist replies back, not a single new. But, so what is it? What is the good news? Number one, we've talked about cancer disparities in general, prostate cancer just being one of them. We've heard about breast cancer and others. The latest data seems to show that the disparities are narrowing. Why is that? Maybe better access, Affordable Care Act, better medical techniques, information, and so on. The second bit of good news is in the recent studies, it seems that African, and we don't know why this is, African American men seem to do as good or better than non-Hispanic whites in many of the treatment options. So that's the story on prostate cancer. I would really urge you and your men to get screened appropriately. The earlier we treat it, the more likely we're going to get a cure. The earlier we treat it, the less likely we're going to deal with some of those concerning side effects of treatment, including urinary and sexual issues. I'm happy to answer any questions.